Good evening, everyone, and thank you for joining us. My name is Melanie Ionase. I am a physician relations specialist here at Rothman. Tonight's webinar is with Dr. Selene Parekh. Office locations are Bensalem, Newtown, and Princeton. Topic that he'll be covering this evening is cutting-edge innovations in foot and ankle injuries. This will be an insightful virtual discussion focused on latest breakthroughs in foot and ankle injury treatments, discovering cutting-edge surgical techniques, innovation techniques, and personalized approaches transforming the field. We will learn how these advancements are revolutionizing patient care and improving outcomes. Let's get empowered through your journey for foot and ankle health. We hope you gain valuable knowledge from a seasoned expert and empower yourself with informed choices for optimal health. Just a few quick notes. At the bottom of your screen, you will see a Q&A icon where you can enter any questions you may have throughout the presentation, and we will have time at the end to answer as many questions as he can. Also in the chat box, I will provide Rothman's phone number if you'd like to make an appointment, as well as my information. You can email me at any time. The webinar is being recorded and will be emailed to all of you within 7 to 10 days. So without further delay, I will pass this off to Dr. Parekh. We welcome and thank you for your time this evening.
Thanks, Melanie, and thanks everybody for joining tonight. This is going to be a whirlwind lecture in cutting-edge innovations in foot and ankle. Orthopedics is a large field. Foot and ankle is a subset of that field, and the pace of innovation and how it's the implications it has on clinicians like myself and how we treat patients is changing dramatically. So I'm going to talk to you guys about things that we have been part of and that we are implementing in our practice for the last 5 to 10 years. Here are disclosures that I have. First off, minimally invasive surgery has changed foot and ankle the last 5 to 7 years. And we've taken what are traditionally larger incisions and shrunk them down to very small incisions, millimeters thick. It's a specialized surgical approach, but the idea is to decrease surgical disruption of the soft tissues and trauma to other areas of the foot and ankle that we normally would have happen with open incisions. So small incisions, specialized instruments to access the foot and ankle for whatever we may be addressing. And we do use a lot of advanced imaging and technologies and special instruments to do this. So one of the most common indications for minimally invasive surgery is bunion surgery. And there's a lot of varieties of bunions, from the mild all the way to severe. So here's a patient of mine, 46 years old, had a bunion, increasing pain. These are her x-rays. We are trying to respect the anatomy, the muscles, the tendons, the nerves, the ligaments, and perform a surgery where we can put the foot and the big toe in better alignment with hardware in place. And so it's a stepwise approach. We put in special wires, we do special cuts, we then put in the screws, do more wiring and more cuts, and we take what would be a traditional incision, like you see on the left-hand side, a large incision, usually 4 or 5 centimeters in length, and instead we're doing multiple poke hole incisions, about 5 of them, each about 3 millimeters in length. And all of that allows patients to recover faster, not have the soft tissue disruption, and avoid wound complications that you can see with open surgery. Now, not all surgeries can be done minimally invasively, but bunions is one of them. Here's another one. This is a patient of mine who had a high arch. The heels are moving inwards, and they are walking more on the outer part of their foot. And so 55-year-old individual having this deformity, coming in with more pain on the outer part of the foot. And so when we get some of our imaging, we can see that this heel is leaning inwards. And so our traditional approach is to use these big incisions, particularly the one at the heel. I want you to see kind of at the back of the heel, the angled incision. And we can, instead of taking this big incision, one poke hole incision, we can do this bone cut. You see that single screw going through the heel? That's the cut and the screw that we're able to put in through one little poke hole incision. And that can dramatically change the soft tissue disruption by lessening the disruption with minimally invasive technique. Now, the bone still takes the same amount of time to heal, but it's all that soft tissue disruption and the avoidance of soft tissue damage that happens with minimally invasive surgery. Here's a patient who had this really large deformity. From the shin bone, the foot was rolling inwards, and we brought them to the operating room. We did this bone cut. Where the plate is located, we did a traditional open incision, but where the smaller bone is cut, we did this through a small poke hole incision. We normally would have done that with a bigger incision as well. Here's a patient of mine who came from the Middle East, had a version of polio, and his feet were really turned in. That picture on the top right is not his feet, but it was very similar to that. Very small, atrophied muscles. And we brought him to the operating room and did this open surgical technique. Lots of plates, multiple screws. You can see the staples, a lot of big incisions. Well, this ended up getting infected. We ended up taking out the hardware and we saved his foot. But after we took out all the hardware and cleared the infection, I told him, I can't do the rest of the surgery because it's with an open technique and I won't take the chance that you lose your foot. Well, minimally invasive surgery then developed and we adopted that into our practice. And I said, you know what? Now we can do this minimally invasively. So we did this hybrid technique where we can minimally invasively do the bone cuts, realign the foot, finishing off the surgery that we had started, putting them in this, what's called an external fixator, which is what you see here, this frame that sends pins into the bones and holds the bones in the right alignment. And he goes on to heal and goes on to have a lined up foot without the risks of the open surgery that he had had on his primary surgery. Now, I don't know if you're going to hear this, but I want to show you the next pathology, which is an Achilles tendon rupture. And I don't know if you'll be able to hear this, but I'm going to try. All right, that's the pop of an Achilles tendon rupture if you've never heard it before. Hopefully none of you guys are eating right now. But Achilles tears are fairly common. We hear about it a lot in the athletic population. Kobe Bryant is one of the more famous individuals, athletes that had this done. And he had it in the traditional technique. If you look at the back of his leg, he had this large incision about 10 to 12 centimeters in length, and it's fraught with a lot of wound complications. We don't do this anymore. Again, minimally invasive techniques. This is one that I developed. It's about a 2 centimeter technique versus a 10 to 12 centimeter technique. We can actually open up the back of the Achilles. We can grab the two stumps. We can put the sutures across those stumps. We can tie the tendon together and we can reinforce it. And this is one of my pro athletes. He gave me permission to use this video. He actually posted this on social media, but I want to show you what you're able to do without waiting for a big incision to heal, where you can mobilize faster.
Keep going. When they tell you you can't, come on, man. Who are they? When they tell you you're not going to make it, don't believe them, man. Don't believe them. You got to be relentless. Don't give up. Don't give up. Stay in it. Stay focused. Quitting guarantees the failure. Once you quit, it rules out any chance of succeeding. The mere waking up every...
So the traditional techniques, traditional ways of healing, it's 9 to 11 months for a pro athlete to get back to playing, and 1/3 of them never gets back onto the playing field. He's doing these box jumps 4.5 months out of surgery. Because of these smaller incisions, because of the reinforcement that we're doing, these guys are able to rehab quicker, faster, sooner. And Aaron Rodgers this past NFL season is a classic example of an athlete who has an Achilles tendon rupture and has the potential to return in the same season. So that's minimally invasive surgery for Achilles ruptures. Now, the ankle is at risk to develop what's called a fibular fracture. Every time you roll your ankle, every time you sprain your ankle, that puts the ankle at risk for developing a fracture. The fibula is that small bone on the outer part of your leg. So if you touch your ankle and I feel that knob, that's the lower end of the fibula. They come in a variety of different orientations, this fracture, but the goal of treatment when somebody fractures it for surgeons is to bring patients to the operating room to try to put the bones in the joint back where it belongs, try to maintain that position throughout the healing, and then try to get the patients moving as quickly as possible. But the problem is with traditional techniques, big incisions, you can have wound complications, and then that wound can fall apart. You have exposed hardware, and now this is a setup for an infection. And if the infection gets into bones, it can lead to multiple surgeries, and sometimes it can lead to bone to the limb being lost, an amputation. And so one of the things we had developed is this minimally invasive nail, where you can achieve the same kind of alignment goals that you have as a surgeon, but you can do it through these small incisions. So you can see the picture there, the small incisions that are used to put this nail into place, to lock it into place. And here's a comparison of the traditional typical plate incision and the typical nail incision. And if you Google NHL fibular nail, one of the NHL goalies about 3 seasons ago in the Stanley Cup finals returned back to playing in the finals 3 days out from his nail being placed into his fibula, into his ankle fracture. That's not something you could do before minimally invasive nail surgery. And so this is a patient of ours, 29 days out from surgery, is now walking without a boot, doing well with a fractured ankle on both sides of that ankle joint. Again, you can't do this without minimally invasive techniques. So minimally invasive techniques in general help to reduce postoperative pain and discomfort because we're not disrupting the soft tissues, faster recovery times, fewer scarring tissues, fewer incisions, small incisions, minimal bone loss, and reduced risk of infections. All right, we're going to switch gears to something else that's revolutionized foot and ankle over the last decade, and that's 3D printing and custom implants. Now, when we think about 3D printing, it's basically where we can take a CT scan, we can give it to the engineers of whatever company makes these implants, they put it together into a software, and they provide us what's called a CAD drawing, and the surgeons talk to the engineers, and we plan the surgery on those diagrams. And then once we finalize what we're going to do and what implants we need, the companies will then print the whatever it is that we need. Now, the advantages of 3D printing, we can create some really complicated geometries that you can't do with normal manufacturing techniques. Because you're only printing what you need, the cost of goods drops. You can never print the complexity figures I showed there. You can't manufacture that, but you can print it. And the printing of one of those is cheaper than trying to manufacture that in normal manufacturing techniques. It can be very personalized and individualized. In fact, that's the goal of 3D printing custom patient-specific implants, to make this personalized to the individual patient. And because all the planning is done beforehand with the engineers, it helps to make these surgeries much easier in the operating room. So custom instruments is what first developed for 3D printing, and that's what we started deploying first. So here's a patient of ours with ankle arthritis. I had done this fusion procedure, but the ankle was arthritic. We custom made these 3D printing guides that we open the joint like we normally do. We snap these guides into place on the bone. We lock it into place with the pins, and then we do our bone cuts and put the implant in like we normally do. And this has been shown to save in some ORs up to 20 minutes of OR time. So quicker surgeries, makes it easier for the surgeon to do. Very nice application for 3D printing. Here's a patient of mine with a bunion, but also has what's called a rotational deformity associated with this bunion. And this is a tough procedure to do because you're trying to correct this deformity in multiple planes of motion. And so what we can do is 3D print a custom guide, which is what you see in the middle here. The guide is created specifically for the type of bone cut we're going to do. And then we 3D print a plate. Now, when the plates get pushed onto the bone over these pins, it will automatically correct the deformity, the bunion, in all the planes of freedom. And so it takes what would be a very complicated surgery and dumbs it down for the surgeon. And so this is a patient who went on to have a correction. She was happy with this and has gone on to live life and been very happy. Here's a patient of ours with ankle arthritis, but the ankle itself, you can see, is not perpendicular to the bone you see. It's actually kind of tilted inwards. So this patient not only has ankle arthritis, but has what's called a varus ankle and is walking more on the outer part of her foot. The arthritis is mild to moderate, not severe. And so we can use 3D printing to 3D print a plate with this wedge to plan our bone cuts and recreate the alignment more anatomic. And takes what's very complicated as a surgery and dumbs it down. And this patient has gone on to have pain relief. The ankle arthritis is not really that painful and has not yet needed an ankle replacement. All right. So that's all custom guides. What becomes even more exciting are custom metal implants. And so we can recreate bones with custom metal implants. So here's a surgeon who had an infection in the middle of the foot, had multiple surgeries, clean out that infection. The infection persisted and was now offered an amputation. Patient then came to see me and we said, yes, amputation is possible, but we can 3D print a replacement to that bone and fuse or lock the whole middle of your foot to stabilize this custom cage we're going to make, but it'll allow you to keep your foot. You'll lose a little bit of motion, but you'll keep your foot. So step one was to clear the infection out. So we go in, take out any bone that looks suspicious, put this bright white substance, which is the cement spacer. We treat them with antibiotics, clear out the infection. While we're doing that, we plan for this 3D printed cage, which you can see here. There's this big bone cap we have to fill, and you can see it on the lower left-hand side. So we bring the patient back to the operating room. We fill up this cage with a bone for the patient, bone from cadaver, and some protein that stimulates healing. And we lock the middle of the foot up. And this patient has gone on to keep their foot, is back to operating and taking care of other patients, has an active lifestyle. Here's a patient that I inherited who had an ankle fracture that got infected. The surgeon who took care of this patient then tried to do a fusion of this joint, which got infected, and now was offered an amputation. So again, came in to see us. We said, okay, step one is to take all the old hardware, clear the infection, and then try to salvage the leg. So here we are. We took out all that hardware, cleaned out all the dead bone. We're holding the bone, the alignment of the leg in proper alignment. And we started creating what I call the Death Star, which is this spherical implant that allows multiple hardware parts to go through it. It allows a big nail to go through it, and you'll see that in the next X-ray, and additional screws if we need it. So this is allows for bone growth to occur through this implant. So this patient had this procedure done, has saved the limb, cleared the infection, and is doing well, salvaging their lower extremity. Here's a patient I inherited 2 years before seeing me, had this fracture of the shin bone. That fracture went on to heal according to the surgeon who took care of him. And he came in to see me. Now, we get multiple x-rays on these views when we see these patients. And so this is the side view. It kind of looks well aligned, but when we look at other views, you can see this whole leg is tilted inwards. And this patient can't even work, let alone walk on this leg. Came in to see me to see if there was anything else we could do. And we did multiple things. We brought him to the operating room. We took out every part of the bone that looked questionable or dead or infected. We held the alignment where we needed with an external fixator. We thought that there was an infection, so we had the infectious disease folks clear the infection out. In the meantime, I had my plastic surgery colleagues bring in some new tissue, bring in some soft tissue, and bring in coverage to this area so that fresh blood supply could come to this area. We planned for a cage using his other leg as the template to find out the bone loss we had on this leg. And so this is a cage. We pack it with some of his bone, cadaver bone, protein that stimulates healing. We put it into place. We put a rod down his shin bone, which is a tibia. And 2 weeks out from surgery, he is now walking on the bottom of his foot. He hadn't done that for 2 years. This guy is now about 8 years out from the surgery, back to gainful employment on the coast of North Carolina, and doing well. Here's a patient of ours at 19 years old. Dad had got onto social media, saw what we were doing with 3D printing, reached out to us because the daughter, when she was in her young teenage years, had leukemia, was exposed to high-dose steroids. The high-dose steroids can cause bone to die. So I'm going to show you an MRI here of her foot in multiple planes, but everything in the middle of the ankle is dead. That bone right there is called the talus bone. It's dying. It's called avascular necrosis, and it can happen with steroid exposure. So his daughter is having a lot of pain with walking. Now, the traditional way to deal with this is to fuse or lock this whole ankle and the joint beneath the ankle up, which means you will lose all your up and down motion and most of your inside-outside motion. To get that done on both extremities, because both are bothering her, is very hard for a patient then to get up out of a chair, get off of the toilet, go up and down stairs. So it's very debilitating to get that surgery. So he reached out to us to see if there were opportunities to save motion. And there are. So using 3D printing, we did the CAD drawing, recreated the anatomy, 3D printed the talus, and here we are going into the ankle joint, taking out that talar bone. Once we take it out, we have these trials, these plastic trials We have 3 sizes of the implant with us. The one that is the normal size, we have 10% larger, 10% smaller, and we trial the one that will fit in the best. Once we find the one that we fit in the best, we put that final implant in, and you can see that instead of being locked up, she now has motion in her ankle and the joint beneath her ankle. And this you cannot achieve without 3D printing. She did so well. 6 months later, she got the other one done. And that holiday season, Dad calls me crying, telling me, Dr. Parekh, this is the first time my daughter in her teenage life is at the mall shopping for the holidays because she feels so good. That is the power of 3D printing. This is a patient of mine, 3 months out from her surgery, is doing box jumps at the gym because she feels so good after her talus replacement. Again, we could not do this without 3D printing. So you get more and more comfortable with the types of procedures you do after you do a bunch of these isolated talus replacements. This is a patient with ankle arthritis and talar AVN. We can do what's called a tator procedure or a combination procedure, which is a total ankle with a total talus replacement. This is a patient who has ankle arthritis, AVN of the talus, and subtalar arthritis, and we can do a total ankle, a total talus, and a fusion of this, what's called the subtalar joint underneath it, and they maintain motion of the ankle joint. Here's a patient that I had done a ankle replacement on, did well for 4 years, then came back to see me because the implant of the talus had sunk into the bone. Basically, that talar bone started dying, and so the implant sunk into the bone. Now, before 3D printing, the only option for this patient was to remove the entire ankle replacement and lock that ankle up, which means this patient will lose all the up and down motion. But with 3D printing, we don't need to do that. We can actually replace the failed implant, take it out, and have the undersurface of the implant grow along the entire surface of the remaining bone. So this is what it looks like. So we're able to give this patient motion back using 3D printing to replace the anatomy that he had lost from bone death. Here's a patient of mine, 19 years old, lost control of her car, smashed into a wall, was in the trauma bay. Both ankles are involved. Her left ankle, the talar bone, the center bone of her ankle, had shot out of her leg. This was an open injury, and she was offered what's called a primary amputation that night. Mom begged the trauma surgeons not to do that, so they didn't. She went back to the scene of the accident the next day, found the bone, brought it to the hospital. They said, we can't do anything with this at this point. She really needs an amputation. Again, mom got onto social media. One of the benefits of social media for patients, found what we did, had this team send her up to us. So these are her x-rays when she got sent up to us. Part of her talus is missing, but the curious thing is she's also missing part of the inner knob of her ankle called the medial malleolus. So if you touch the inner part of your ankle, that knob you feel, that's called the medial malleolus. She was missing that as well. So we thought, well, maybe we can replace both the talus and the medial malleolus. So we start planning all of this. We recreate the medial malleolus with metal. We recreate the talus. We use her uninjured side, well, her other side as the template to create this. And she's about 5 years out from the surgery. She has both limbs. She's dressing up. She's not perfect, but she's able to dress up and have a leg and live a somewhat normal life that she wouldn't have done with an amputation. Here's a patient from Hawaii, had this injury, came in to see us. In Hawaii, he had this pinning done, ended up getting infected, came in to see us, had this really bad infection, so we had to clear all that out. So here we are clearing all that out. He grew out a type of bacteria called Propionibacterium. And this is one of the first ones that I had done where we not only fused underneath the talus, but also in front of the talus. And so this is what it looks like in the operating room. You can see the slurry of the patient's bone, the cadaver bone, and the bone protein on the ingrowth surfaces of this implant. And here we are in the operating room, not only giving him a total ankle, but a total talus, a fusion underneath, and a fusion in front. And this patient's about 6 years out from surgery, back to gainful employment and doing well, and salvaged a limb. Here's an extreme case of ours, a patient that I had done one of the traditional approaches where we did a fusion with a nail. And one of the reasons why 3D printing is so powerful is that this technique of what is traditionally done is fraught with complications of the ankle not healing and the joint beneath the ankle not healing. So she did okay for about 5-6 years, and then came in to see me because of increasing pain. And we got the CT scan, and we can see both of those joints, the ankle and the subtalar joint, have not healed. So by now, 3D printing has really affected my practice, and I've got a lot of confidence in 3D printing. So I'm like, well, maybe I can reverse it. So we bring her back to the operating room. We take out all the hardware. We put bone graft into the canal where the nail was. We put a cement spacer into place. About 6 to 8 weeks later, we give her an ankle replacement with a talus replacement and a fusion underneath. Now she has motion. It's not normal motion, but she has enough motion to walk without a limp. And she chuckles every time I see her and says, Dr. Parekh, why didn't you do this from the beginning? Well, we didn't have the technology when we first started this care for her. So how do these patients do? Pain is usually about 1 or 2 versus 9 or 10 where they were. I have a firefighter who's back on the force. I have a golfer who plays 18 holes of golf 3 times a week. I have a patient who won the senior game. I showed you the one who does the box jumps, and they're doing fairly well. Okay, so 3D printing has changed the pathologies we can treat, and also changed options of motion sparing options and limb sparing options that we can offer patients. So now we're going to shift to regenerative medicine. Regenerative medicine is really starting to invade what we do in foot and ankle. It comes to us from the professional athlete world, and really is about stem cells. And when we think about mesenchymal stem cells, they are cells of the human body that can almost become any other tissue of the human body. So they can differentiate to become a lot of different cells, or a lot of different tissues. Now, they can also affect the local environment by producing proteins, growth factors that manipulate the local environment to change that environment from one that is inflammatory to one that is more healing. And they do that from a variety of different mechanisms. All right. They can affect a lot of different inflammatory cells based on the growth factors that they are creating. And so what the stem cell does, think of it as a power plant that has different antennas on it. And so with the antennas, the power plant is sensing, what does this local environment need? And when it figures out what it needs, it tells the manufacturing equipment in the power plant to start manufacturing that specific protein that'll change the environment around it. And so it's smarter than PRP, more elegant than PRP, and in my experience so far has been more effective. All right. And has been highly anti-inflammatory. Now, you can get stem cells, mesenchymal stem cells, from your bone marrow, and there are times that we're going to use that, or you can get it from the fat in your body. And we'll talk about that in a minute. So when you get it from the bone, you can get it from a variety of different places. You can get it from the iliac crest, kind of where your pants sit on your waist. You can get it from there. You can get it from the shin bone, and you can get it from the heel bone. Now, when we're in the operating room and dealing with foot and ankle pathology, I like to get it from the heel bone because it's all part of the same pain experience for the patient and not a second site of pain. But you can also get it from the fat, all right? Fat may be the ideal source for stem cells. It has a higher regenerative capacity than your bone marrow cells, and higher than peripheral blood as well. So these fat stem cells live in the fat around your belly, around your gluteal area, and around your thigh. The cool thing about the fat stem cells is they do not age out as you age. What I mean by that is bone marrow stem cells will get older as you will get older. But for whatever reason, the behavior of the stem cells around the fat don't do that. So that's one amazing thing about the fat stem cells. The second thing is volume is tremendous, right? You can get as much volume as you need from multiple sites as you want. It's minimally invasive for us to get it. It's like liposuction that we do in the office, and they can provide cushion and support. So here's a patient of mine who we're doing this on. First off, in this part of the video, we are injecting numbing medication, kind of like Novocaine you get with a dentist to numb up the belly. Then we are going to harvest. This is like a cheese grater that we're putting in and out of the abdomen to kind of harvest the stem cells and the fat. Next, we will like a margarita shaker, kind of take the fat, put it into a micronize it is what it's called, put it into a lot of small pieces, and we're isolating the layer of the stem cells. And then what we do is we put it into a syringe and we will re-inject it into the patient. Now, in the US, you cannot manipulate these stem cells. You can't add things to it. You can't add proteins to it. You cannot heat it up. You can't cool it down. That is not allowed by the FDA. But we know that stem cells can support bone growth and be anti-inflammatory. So for me, when I need to support bone growth, I'm taking bone marrow-based stem cells. This is for your osteochondral lesions of the talus. If you have swelling in the bone, stress fractures in the bone, we're trying to do fusions, trying to take care of fractures, trying to take care of fractures that haven't healed, then we're taking stem cells from the bone. If I have a patient who's got more of an inflammatory issue, like plantar fasciitis, like tendonitis, like arthritis, like of the ankle, of the knee, then I'm using fat-based stem cells. So to return to that patient, she had plantar fasciitis. And what we are doing here is we take that syringe, we inject it into her heel, and we put all the fat that we injected into her heels to treat her plantar fasciitis. So my experience so far is patients get about half of their full relief within the first week. It seems to be effective. They get this bimodal experience where that first week they get about 50% of pain relief. You lose a little bit of that, and then you get to sustained pain relief. I've done about 30 of these and had about one failure that ended up needing surgery. We don't have long-term data on this, right? This is fairly new in the US. We don't have 10, 15-year data to know if these patients forever can delay surgery, but we certainly know we can get some time to delay surgery. I've done this for arthritis of the big toe, ankle arthritis, knee arthritis, tendonitis of the posterior tibial tendon, of the peroneal tendons, of the Achilles tendons. And I'm going to show you some cases. Here's a patient that came in to see me, has this a bright area in their ankle. This is a cyst in their ankle, and around the ankle, there's a lot of reaction in the bone. That's called bone marrow edema. So we went in there, scoped it all out, cleaned it all out, and injected bone marrow-based stem cells into the bone. 7 months out, she's crying in my office because she had just completed a 9-mile hike. And bottom line is, we're able to restore quality of life. And that's really what we're trying to do here. Here's a patient of mine who had a procedure done for avascular necrosis in the center of her bone, the center of the talus. This was very mild avascular necrosis. And what we can do is go in there, put in the bone marrow-based stem cells, reinforce the bone with screws, and she's gone on to do well, and she runs and does well with that. All right, so we can change it up. I got about 2 more topics to hit. Synthetic grafts and new materials are really changing what we can do for patients. You know, this is one of the most famous ankle sprains. Mahomes 2 seasons ago had this really bad ankle sprain, thought it would end their playoff run, but he came back to play. About 25,000 ankle sprains happen per day in the US alone. Thankfully, not every single one of them needs surgery, because otherwise we would be overrunning the healthcare system with surgery. But there are a segment of patients who do need surgery because they develop ankle instability. And the old way of doing it is taking the tissue that tore and suturing it back together. The problem is that tissue quality is not great. So people started trying to reinforce it with anchors, reinforce it with some of the other tissue that's sitting around in the ankle. And it does okay, but you have to keep these patients immobilized for a period of time, usually 6 weeks, and then you're walking them in a boot for a month, and then they're into therapy. So it's a long period of time. So companies have come out with synthetic grafts, and here's one of them. Now, the idea behind synthetic grafts is if you can create something that recreates the elasticity that you see in normal tissue, that is better than having something static. And you can see the difference. If you have something static like a rope and you're going bungee jumping, you're not doing so well. But if you have something that's elastic, it's a lot better. So there are synthetic grafts out there trying to restore stability and natural motion. There are ones that resist necrosis, and they can regenerate natural tissue over time. These grafts, especially the one that we use in our practice, 92% stronger than sutures and anchors alone. And the stiffness is equivalent to the normal tissue of the body. And the cool thing about it, so if you look in the upper right-hand picture, you'll see the grafts that we use, and they come in different lengths and even different widths. But the really cool thing about this graft, it's synthetic. And within 3 to 4 years, your body replaces it with normal collagen of the normal anatomy. So this thing will go away, dissolve away, be replaced by normal anatomy. And that allows us to not only reinforce our primary repair, but we can then mobilize these patients faster because it's stronger. So most of my patients within 2 weeks are walking on it in a boot. And by 6 weeks, they're out of their boot working with therapy. With my pro athletes and my collegiate athletes who are under the supervision of an athletic trainer, they're starting therapy within the first 2 weeks and working on getting back to their sport very, very quickly. Usually within 4 to 6 weeks, they're returning to their sport. Could not do that without these type of synthetic grafts. We're going to turn our attention now to the tendons on the outside of the ankle. So we talked about the ankle instability, which is a ligament issue, but now we're going to talk about peroneal tendons. These two athletes, Kurt Schilling and Von Miller, are two of the more famous athletes with peroneal issues. But the peroneal tendon lives on the outer part of your ankle. It's an unrecognized source of lateral ankle pain or outer ankle pain. And you want to try to recognize this early, because the earlier you get to it, the better patients do. So these two tendons live on the outside part of your ankle, right behind the knob of your ankle joint there. There's two tendons called the peroneal brevis and the peroneal longus, and they are really working to help evert your foot, kind of twist it outwards. Patients come in with pain in that part of the ankle, and on exam, they may be having tenderness over that area. They may have thickening of that area, and they'll likely have weakness. So here's a collegiate athlete who tore their peroneal tendon acutely, and here we are repairing it. We use what's called a tubularization technique. The problem with that tubularization technique, that's the classic way to take care of this, is that it can lead to persistent pain, recurrent tears, and progressive tendinopathy of these tendons. And so what we have done for patients who have lost over 50% of their tendon, we are now trying to do what's called allograft reconstructions, using cadaver tissue to replace the bad tendon. Again, this is for tendons where over 50% of the tendon has been damaged. So here's where I am attaching the tendon, the graft, to the native stump. And here we are attaching it. And we're attaching it to the top part of the tear. And then here I am attaching it to the bottom part of the tear. And so again, this is cadaver tendon being used to replace their damaged tendon. But again, it's more than 50% of that tendon being damaged. So we looked at our first 14 patients who underwent this type of procedure, and across all subjective outcomes, from function, from postoperative function, from pain scores, they improved. Okay, so they did better than those patients who had their traditional approach. Even their strength's better. The question becomes, if you cannot repair these tendons, what we used to do is take the stump of the bad tendon, cut out the bad area, take the two stumps that were remaining, and attach it to the second tendon that was still functioning. So that's called a tenodesis, and that's what we used to do. The problem was with a tenodesis, instead of having two tendons working, you only have one tendon, which means you do have some loss of strength and power. So I had a number of patients who came in to see me, had tenodesis done, and asked me, hey, Dr. Parekh, is there any way to reverse it and give me two tendons back? So with our experience with allografts, we actually started doing that. So all three of these patients had a reversal procedure done, and you can see on the left-hand side, that is the reversal. Two tendons are restored. On the right-hand side, you can see where the one tendon is attached on either side to the good tendon, and these patients had restoration of function and strength. But the really cool thing is for those tears that are less than 50%. Instead of doing the tubularization like I showed you, one of the things we're doing is taking that same synthetic graft that I showed you from the ankle reconstruction, putting it into the core of the torn tendon and wrapping the native tissue around this core. And we are then bringing strength right away to the repair. But secondly, over 4 years, 3 to 4 years, this will become type 1 collagen. And my opinion is that this will have more durability than the tubularization that we were doing in the past. All right, so here's a patient who had this done. All right, let's talk about some materials, because foot and ankle is getting a lot of new materials. This is called more material. It's made out of molybdenum and rhenium. It's a alloy. It is a very strong alloy, and because it's very strong, we can the manufacturer can make these implants much thinner and lower profile than traditional foot and ankle implants. Now think about your foot and ankle. You do not have a lot of muscle coverage. You don't have a lot of soft tissue coverage. So if you have thicker implants, that can lead to hardware irritation down the line. Thinner implants, lower profile, that are same strength, are desirable because hopefully you don't have to have that hardware irritation that leads to a secondary surgery. The cool thing about this implant, this material, it's hypoallergenic and it's antimicrobial. So we are hoping that this leads to fewer infections down the line as well, and fewer rejection issues from the body not liking this metal in there. So talking about allergies, I've become a bigger and bigger proponent of the fact that patients can have allergies to these implants. And this is a patient who had an allergy, got tested through a blood test that's done in Chicago. And with 3D printing, for a lot of patients, they can 3D print metals that do not have their allergic core in it. And this patient had a revision surgery without the metals that she was allergic to, and has gone on to do well and is pain-free for the first time after 2 other surgeries where she had those allergic implants in there. Metal sensitivity, hypersensitivity is a real thing. We published on this. I've got about 20 plus patients now who've had this done where we've taken out metal that they were reacting to and replaced it. Here's a patient who had a different material done. All right, this patient did not have an allergy, was taken care of at a outside of the tri-state area here, and had this total talus replacement done with an ankle replacement. This whole thing was getting infected and was offered an amputation. Came in to see us. We said, we'll give it a shot to try to save the limb. We went in, cleaned out all the hardware, took out all the hardware, cleaned out the infection, put the cement spacer in, put the external fixator on. But this material is called PEKK, P-E-K-K, PEKK. It can be 3D printed to the patient's anatomy. It's it's antimicrobial. So in a patient that has a setting of an infection, this is something that we can now use to salvage a limb. This patient's about 6 months out from surgery, is recovering well, no recurrence of the infection yet. Hopefully we'll never have that recurrence, but it is something that we can offer a patient, and this is what the x-rays look like, and he's doing well. Here's a patient of mine, talar avascular necrosis, but has allergies across the board to almost every metal that we use in metal implants in orthopedics. This patient was not a candidate for a 3D printing implant because they could not create an implant that didn't have any of this material in it. So here we used a PEKK 3D printed implant. This is an implant. You can't see it. It's invisible. It's ghosted. But this implant's in place and she is recovering, and we expect her to do very well. So on that same line of not being able to see implants, metal-less surgery is becoming more and more requested. And we have opportunities to give patients metal-less surgeries in certain indications. So here's a company that makes a metal-less implant. We've been using it for about 7 years. It's an implant that's made out of a natural mineral fiber material. It's very strong, and it biointegrates into the bone. So it doesn't dissolve away. It integrates into the bone and becomes bone. So on this left-hand side, you're seeing a patient who had a fusion of the big toe. You don't see any implants. They're there, but you can't see them. This is the middle picture is a patient who had a fracture on the medial malleolus on the inside of the ankle, has implants in there. Again, you can't see it. And on the right-hand side, you're seeing a patient who had a fusion of the big toe. Again, you can't see the hardware. And so this metal-less surgery is becoming increasingly requested by our patients. And again, we're doing it more and more. Finally, I want to talk about wearable technology and smart orthotics. Smart technologies there, Apple Watch, Oura Ring, Samsung watches, Google, smart orthotics are coming in. There's one that we've really been starting to use in our practice. It's a smart insole with a sensor in it. It's got a web app. It can provide patients with reports. But the really cool thing is it looks at a variety of different metrics in the patient's gait pattern, walking pattern, looking at the right versus the left side. So what we can do is use the data to start saying, okay, Quote unquote, Steph Curry. I'm picking a random athlete. Steph Curry needs surgery, has surgery. How is his injured side doing versus the uninjured side? How close are we to being within normal? Based on that, how fast can we get that patient, that athlete back into playing and doing what they want? And that kind of data is invaluable for us to be able to rehab our patients faster, quicker, sooner, and get them back to their sport quicker, faster, sooner, or their job quicker, faster, sooner. So foot and ankle surgery, I'm just giving you a very high level of exciting innovations that are rapidly evolving and changing what we can offer patients. It ranges from materials and techniques to biointegrative stuff. AR, VR is right around the corner. Robotics is around the corner. Wearables continue to evolve. And for me, this is an exciting place to be, to offer patients cutting edge technologies to help the patient achieve whatever goal they're trying to achieve. And so it's an honor to be able to take care of patients and implement some of these techniques and technologies for these patients. So with that, I'll open the floor to questions, Melanie.
Well, Dr. Parekh, I'm amazed about all the information. I was actually writing my own notes because I've learned so much. So thank you so much. I'm sure everyone is right along with me, just appreciating all this valuable information. So we did have some questions come through, and I will just appropriately go down from the top to the bottom.
Sure.
I have posterior tibia tendon dysfunction, flat foot, and was told the tendon is completely torn. Is there minimally invasive surgery for this?
Somewhat. And what I mean by that is if you need some bone cuts to realign your foot, those oftentimes can be done minimally invasively. The replacement of the tendon is now done. The old techniques, we used to use really long incisions. We can half that incision now. So it's not fully minimally invasive, but somewhat. We would call it more mini open. But yes, some of these techniques have evolved for us to do that for somebody who has a condition like yours.
Thank you. Can you do minimally technique to perform removal of Haglund's deformity? I'm not sure if you touched on that. I'm not too sure what that is.
So as long as there's no Achilles tendon involvement, we can remove the Haglund deformity minimally invasively, and we do that routinely. But you need an MRI to make sure there's no Achilles involvement. If there's Achilles involvement, then we tend to still lean on our traditional open techniques.
Okay, thank you. What is the longevity of 3D ankle implant for a 32-year-old?
That is the $1 million question. So in Asia, they've been using non-3D printed metal implants for about 20 years, and they're showing about 85% longevity with those implants. Our thought is we're 3D printing it. It's patient specific, it's individualized, that we should hopefully have even longer longevity than that. But we don't have data on that yet. This technology has only been around for about 10 years. And I've got some of the latest, the oldest data available globally. And so we're tracking this.
Can't wait to hear the outcomes on that one. So can these materials be used for ankle replacement? And can we reduce non-weight bearing time during healing and recovery?
Depending on your conditions, yeah, a lot of these materials can be used. However, if you're a candidate for just a normal off-the-shelf implant, then there's no reason to use one of these 3D printed implants. But again, it just depends on what you're dealing with.
Okay. What is recovery time for MSC injection for Achilles tendonitis?
Typically, I will allow the patient to weight bear immediately in a boot. We'll protect you in a boot for 2 days. And then after 2 days, you are working with therapy, continuing to work on motion and strength and anti-inflammatory techniques.
How long does it take to recover from bunion surgery?
So interestingly, minimally invasive and open, there are huge advantages, but the bone still takes the same time to heal. So it's 8 weeks before you're back in your shoes. If you tend to heal a little bit faster, maybe you get to 6 weeks. But for the first 6 to 8 weeks, you are walking on it in a special shoe called a post-operative shoe. But that's usually the timeline.
Okay. How would I know if I have a metal allergy?
So first off, we verbally screen every patient. If you think you have, well, first of all, if you have any reaction to jewelry, watches, rings, earrings, you probably should be tested. And so that's the number one alert. If you think that there's a family history, maybe you want to get tested. So those are the things that alert us. Now, if you have never had those issues, we don't normally test people. The reason why we don't normally test everyone, because I get asked this all the time, insurance doesn't cover this test. And there's only one lab in the country that does it out in Chicago. Because not everybody needs it, there's no reason to test everybody.
Have you seen any success with bone stimulators, ultrasounds, EMFs?
Yeah, I'm a big fan of bone stimulators. I think they do work in the right occasion. I think they supplement whatever else we've done, whether it's surgery, whether it's non-weight bearing periods for different fractures, but I think they're a great supplement. Again, the problem with bone stimulators is most insurances don't cover it till you pass the 3-month mark.
I'm not sure if I'm saying this right. How is amniox different from my own stem cells?
So amniox is amniotic-based tissue. Stem cells that are harvested from you, especially the fat, have been shown to be more powerful than the amniotic allograft tissue. So if in my practice, if I have an option, I want to use your own stem cells.
Okay. What specific foot and ankle conditions can be treated with synthetic grafts like you spoke of?
So it varies, but different tendon pathologies, the peroneal tendon, we've done it for the Achilles tendon. We have not done it for the posterior tibial tendon because usually by the time we see them, those have to just be replaced fully. The ligament reconstructions, whether it's lateral, medial, spring ligament, we've done it for, people have done it for different ligament issues in the toes. So it's just continuing to evolve.
What foot and ankle conditions have you found that benefited the most with stem cell therapy?
The ones that I've shown on that list. So arthritis of the big toe, arthritis of the ankle, arthritis of the knee, plantar fasciitis, Achilles tendonitis, peroneal tendonitis, and posterior tibial tendonitis. All those itis stem cells from the fat tend to be very good for.
What is typical rehab duration for total ankle replacement versus a fusion, and how long is the duration of restrictions following each?
Yeah, so if you get a ankle fusion, so let's talk about isolated ankle fusion, you're typically in a cast, not walking on it anywhere from 6 to 10 weeks, depending on how fast you create bone. And then after that period of non-weight bearing, you're in a boot for a month, and then you're back in your shoes. So the time to get back into your shoes, 10 to 14 weeks. With an isolated ankle replacement, so no fusion, no bone work, nothing else done, just an ankle replacement, you're non-weight bearing for 3 weeks. After 3 weeks, you're walking on it in a boot, and at week 6, you're back in your shoes working with therapy. So the timeline back to shoes, 6 weeks versus 10 to 14 weeks.
Wonderful. Well, I think we covered all the questions. I'm sure some come in later on. We'll get back to you. If anyone has any further questions, feel free to email me at melanie.ionace@rothmanortho.com. I will pass this along to him and we will get answers back to you guys. Thank you so much, Dr. Parekh, for all your time. This was amazing. I've learned so much myself, as I'm sure everyone else did that attended this evening. And again, the video will be sent to your email because you did register through our Rothman website. It'll go out in a few days. And any questions, feel free to reach out to us. And we thank you so much for your time this evening for everyone.
Thanks, Melanie, and thanks everybody for joining.
All right. Have a good night.
Good night.